Hello, Sanjay. Sanjay,
Yes, sir.
Yeah,
Yes,
audible,
sir.
sir.
You
Audible?
are audible. Continue.
now extremely sorry for the disturbance, which is due to technical problem, which I'm not aware of that because I'm physically strong and digitally very weak. And we're again reviving that. Sorry for that, viewers. The suction devices. There are various types of suction devices. The Younger device in A, B is the Frazier type, and Pool is the C variety, where we can use it in as a swamp suction. And we can use the fiber optic devices along with that also. And that is very important suction. I believe that less use of mop, more use of suction during surgery, both in the obstetrics as well as gynecological practice. It could be a disposable like Rumson C here, and the reusable like the Younger variety. This is the commonest thing, oldest thing, which is very in abdominal surgery we can use it. But for vaginal and also abdominal, this particular variety of Pool variety, which is a swamp suction, is very useful for that. You detach it and use it in a case of vaginal, put it in a case of the abdominal in case which combine these two so that the suction will be very good for that. So suction is a very important equipment for the conventional surgery for that. Now coming to the retractors. Retractors again, it could be abdominal retractors versus vaginal retractors. It could be self-retaining versus handheld. And Burforce and Doyens are the two retractors which are very commonly used long since for decades in abdominal surgery. Until today, Doyens has become part and parcel of the obstetricians and gynecologists for that. And this is the example of Balfour self-retaining on the right side. And along with that, the Doyen has been attached. And on the left side, you can see the Hiney, the Diver, the Richardson, and the Brisket type of retractor, which can be used particularly for abdominal surgery in that case. And this is one of the example where you can see the Burforce retractor, and it can be attached to the Doyen. And on the left side, we can see the Doyen, then the two type different designs of Doyen. And this one is the square retractor, which is there for that. And this is the Landau's retractor. The smaller retractors can retract some of the vessels during the surgery in pelvic lymphadenectomy for that. So the various types of retractor which can use it. You choose 2 or 3 retractors, which is very useful for that. Don't jumble up the instruments in one trolley and put it all the retractors that is necessary for that. At times you use the extreme left is the diverse retractor with the fiber optic source, and that also helps in where the retractors are very important, particularly for the sacrospinous fixation, which people do it, or in a case of abdominal surgery in gynecology, people can do it for that. But vaginal retractors is very familiar with all the vaginal surgeons and gynecologists. It could be self-retaining, it could be handheld. The commonest Sims, Marian Sims designed a bivalve speculum was there for long time for that. And now for this surgical aspect in vaginal surgery, single-bladed speculum is much more beneficial than the Sims bivalve speculum. And the fiber optic speculum in a deep seated, particularly where the visibility is a problem, where the fiber optics can illuminate that particular deeper level where we can do the surgery much more better, and it's not a blind surgery for that. And it could be variable sizes and designs for that. And these are some of the Sims speculum. On the right side, we find the double valve speculum. On the left side, we find the different crystallar variety of the Sims, single-bladed vaginal speculum for that. And here are few of these speculums, vaginal speculum. I've shown you the commonest, these 3 we're using it. The commonest, the 3 single-bladed, different sizes are enough for that. Even 2, one in the posterior vaginal P pouch, another in the anterior pouch. So these are the very essential equipment for the vaginal hysterectomy. You can see these 3 and the different dimensions that you can use it. 4 single-bladed vaginal speculum of different caliber, and that is necessary, and that is enough for all types of vaginal hysterectomy. We can use it for that. And these are all square type designs for that, and we always favor a round type where the injury to the bladder or injury to the deeper structures is less as compared to the square designs for that. Now next common is the catheters. The commonly used catheters earlier way back we are using the ordinary rubber catheter that has been replaced by the synthetic Nilaton's catheter. A single-use disposable catheter, Nilatans, is commonly used, and commonly before surgery, we were using the metallic female catheter, which you see in the extreme left, and this is a metallic catheter which is there, and this metallic catheter helps in during the type of before the surgery in evacuating the bladder, number one. Second important, during the surgery in a case of cystocele, the limit of the bladder can be well defined by introducing this metallic catheter for that. That's the main advantage for that. Otherwise, Nilaton's catheter for the single use, but for continuous indwelling catheter, the Foley's catheter is a very useful instrument for that. And Dr. Foley has devised this catheter particularly for the urological surgery in the prostate, for a compression, for a tamponade. And since that time, for a longer time, this is there. We use the varieties of Foley's catheter, pediatric catheter, and different types of Foley catheter, not only for tamponade, as he has used in prostate, we can use it in the uterine cavity, particularly after surgery in bleeding, to arrest bleeding in a hysteroscopic surgery, or in a cervical pregnancy. These are the cases which can add in a tamponade, or in a case of a rescue circlage, this can be used, and this is a very useful instrument for that. And apart from it, the common use is indwelling catheter for a drainage of urine. If it is required, you have done a bladder repair and all that, you have to put it for a longer period of time. So Foley's catheter, for a few days to few weeks also, you can keep it, and that is disposable catheter which is connected to the urobag and continuous drainage of that. This is important. Catheter drains are also very important. I remember the indications of drain. What are the indications of drain? I think when in doubt, drain. That should be there. But don't have a doubt in that. You have to be very clear about it. But there are generalized oozing, or there is a pus pocket, or there is a surgery where you want to drain it because there is some fluids, transudates or exudates, which is there for that. So drains are essential, not only in the subcutaneous tissue in the parietal wall, but inside the peritoneum, or doing a vaginal hysterectomy, you can put a drain in the middle central part for that. So the corrugated Romson drain is very important. Earlier, the ordinary rubber drain was being used, or Romovac drain. Romovac is a very useful drain. The drainage is very important because the drainage is a constant suction drain is there. Romovac is a very good drain, but it cannot be used inside the peritoneal cavity. That's a very important. When a closed cavity, Romovac drain is the best. But in the abdominal cavity, Romoedic is a wide bore, and it can drain much more better than the Riles tube, particularly for that. And corrugated Romson is a commonly used drain for that. And the gauze drain, normally we in gynecological surgery, in vaginal surgery, if they find the raw area in the posterior surface of the uterus is there because of the adhesions in the rectosigmoid, and there is a small amount of oozing there, it cannot be controlled with the coagulation for that. And there we put a gauze drain to keep it draining for that, and that soaks also. That's very good for 24 hours. You keep it and then remove it for that after that. Now coming to the needles. The needle is very important. Earlier when we used two types of needle, atraumatic needle as well as with the eye. We are used to the eye because atraumatic was not that available and popular. Nowadays, the eye needle has been already gone to the graveyard, so that usually the commonly employed needle are the atraumatic needle, and that is many advantages of atraumatic needle, though the cost is quite a little bit more, but still we are habituated with the atraumatic needle of various types. It has a tip, it has a body, and it has a site of suture attachment, the swage. And the swaged or atraumatic is a very important sutures, needles, particularly with suture, which is being used for that. It varying sizes, it has shapes and the tips. And the varying sizes, tips means it is a curvature also varies. It could be straight needle is not being used commonly by gynecologists. It's always carved needle. It could be carved round body. It could be carved the round bodied, or it could be taper cut or a cutting needle. Taper cut and cutting, these are all for tough structures we are using it, but round body needle is being used. And the dimensions also vary, starting from a 30 millimeter half circle to 3/8 circle to various different designs of length, starting from 30 millimeter to 45 millimeter to large needle for that, but it's a carb needle which is very important for that. And other needles are the cobbler's needle, which helps us, or the port closer needle in laparoscopic surgery, we use it for that. And this is one of the example where there's a taper point, blunt point, reverse cutting, and conventional cutting. Reverse cutting is one that the reverse direction there is a cut. You can find the body and the tip and find out the cutting particularly for that. And this is what is known as the reverse cutting for that. This is the conventional cutting where the tip cuts, and these are all blunt needle which is being used. And it could be either a 1/4 circle or half circle, or 1/4 circle or 3/8 circle or half circle. And the needle cord length determines this needle point to the swaths. And the needle, this is called a needle length. The body is in between, and the radius is the total diameter of the needle for that. And you see, this is what is the needle with the sutures attachment for that. And that is of various designs and sizes. And nowadays, the suture also, the dimensions, I will come after a little time to the suture. But this is classical, a round-bodied needle with the vicryl. And this is atraumatic. This was needle for that. And the other one, you can see that this is a polyamide reverse cutting. And the 3-0 polyamide reverse cutting best suited for skin closure. And for this is important, the reverse cutting needle, and attached it with the polyamide for that. So this is how the needle dimensions can vary, and that can be used on various types of sutures for that. And this is what I was telling about the port closure, the suture carrier. These are all called suture carrier. And this is the part you can see that suture is incorporated there so that it carries. And this is important. Doing a common procedure involved fixation in vaginal wall, where we fix it with the fixation of the Macken rods and uterosacral in a case of prolapse, or in a case of wall prolapse, where you just put it inside and then draw it. This is what is called a cobbler's needle, and attachment of that, you introduce it, and very easily you can put it for that, so that the surgery becomes very easy for that. A simple, earlier we used to put the needle inside the eye, and then dragging it takes a lot of time and inconvenience. So this cobbler needle is a very useful needle, and needle carrier, suture carrier for that. And this is one example of port closer needle, a very simple design. It is a spring-loaded device where it is sharp, and when you push it, the spring, the two ends come, and that you hold it with that, and then with the sharp end, you introduce it and to the peritoneal cavity, then see the other side, and then pull it out for that. So this is a very efficient and a very simple design of port closer needle, which is useful in laparoscopic surgery for that. Now coming to the suture materials. The suture materials could be absorbable, could be delayed absorbable, and non-absorbable. And either it could be monofilament or it could be multifilament. There are various types of suture material which is available, and absorbable. Absorbable, the biological and synthetic. In the biological, we have got a catgut, plain and chromic size, which in our earlier days we were commonly using. That was the only suture which is commonly being used. And then the synthetic sutures came. There are many advantages because of the tissue reactions of that, infection, tissue reaction, and a lot of advantage, the tensile strength, all these. The synthetic sutures, absorbable, has gained over that, and now it's very popularly used. The Dextran, the polyglycolic acid suture. Vicryl is a polyglactin suture, and Vicryl Rapide, which is commonly used, and episiotomy, which is the absorption, it is a relatively less time than the Vicryl polyglactin. PDS is polydioxin. It is also a very tensile strength is very good for the PDS suture, and that can be used in place of Vicryl for that. And now the barbed suture, which is there particularly for laparoscopic surgery, in a laparoscopic myomectomy. In the layered suture, barbed suture saves not only time, but it's a very, very convenient sutures. Barbed suture is only thing is that you have seen the barbed wire. In between, there are multiple nuts in between, whole length of the suture well for that. And that could be varying sizes and lengths. Varying sizes and lengths of the suture diameter could be there. The sizes commonly used by gynecologists and obstetricians are 10 and 1. 10 or 1 is the common dimensions which is being used. On rarely we use a 20 or a 30, or 60 is common only used in a case of the tubal recanalization. Now, nowadays the tubal recanalization incidence has been declining, but still there are some cases where you have a chance to use it. We use this 60 proline, non-absorbable, not a synthetic, or absorbable 60 Vicryl, you can use it for that. And number 4, we use it for cervical encerclage. If you are using the number 4 silk, you can use this as a cervical encerclage suture for that. And the length particularly varies from 75 centimeter to 90 centimeter to 150 centimeter long, with the 2 ends needle. One end could be a round body, another end could be a cutting. So this facilitates the surgery apart from the cast cutting for that. And the barbed suture, we need a less dimensions for that, particularly for laparoscopic surgery. We require a less length, and 24 centimeter, maximum 36 centimeter. If the length is more, it is very difficult to make a suture, and 24 centimeter is the commonest suture in barbed suture, which is being used in a case of laparoscopic surgery for that. And non-absorbable biological is silk and cotton. Cotton, in our student time, we are using a lot of cotton threads by our teachers, and now silk has also been available, non-absorbable. Still, it is being used, although the incidence is less. Synthetic terylene polyamide has become very commonly used, particularly for skin, and polypropylene or proline was being favored for rectus sheath to prevent herniation for that. But now Vicryl has taken place in that. But in cases where there is a hernia repair, or in difficulties where you want a weakness, we expect a weakness in the rectus sheath, I think the proline is a much more better suture for that. And still, we never use it. It was first recommended for cardiothoracic surgeons or orthopedic surgeons for still, but still when gynecology is being least used for that. The suture designation, the USP designation starting from 0 to 5 and 0 to 50, and synthetic absorbable diameter is this one. So suppose normally we use a USP designation of 10, the diameter would be 0.35. If it is a 20, it could be 0.3, but 1 could be 0.4. And if you're using the number 4 silk, it could be 0.6. So these are all derivatives of the diameter in relation to the number which is given 0, 10, 20, 30, like that. Now, this is a specific suture metal characteristics, and the characteristics could be either a configuration, tensile strength, handling, knot security, and reactivity. These are the 5 different criteria on which each suture is being classified. Say, for example, silk is a non-absorbable type. Its configuration is braided, tensile strength is good, handling is good, knot security is good, but the reactivity is high. Nylon is a monofilament, tensile strength is high, handling is fair, not good, and knot security is fair, not good, but reactivity is low. Proline, again, monofilament, the tensile strength is very good, but poor handling, poor knot security, and low reactivity for that. Marceline is a braided synthetic, which the tensile strength is very high, handling is good, knot security is good, and reactivity is moderate. Whereas Ethibond, the braided coated, high tensile strength, fair handling, fair knot security, and moderate reactivity for that. And coming to the absorbable, the catgut, the configuration is twisted, tensile strength is poor, handling is fair, not good, knot security is poor, and reactivity is high. Particularly for chromic, the reactivity is very high. Dextron is a braided, the tensile strength is good, handling is good, knot security is good, and reactivity is also low. So Dextron is a very good suture for that. And same thing with the Vicryl, is a braided, and tensile strength is good, handling is good, but knot security is literally inferior to Dextron, but it's a fairly good for particularly for that. And that's why Vicryl has become commonly used by all gynecologists and obstetricians for that. PDS, again, the advantage of PDS with Vicryl is that it is a monofilament, and the tensile strength is good, the handling is fair, the knot security is poor. That's an inferior quality with the Vicryl, but the reactivity is low. And monocryl, the monofilament, tensile strength is good, fair, handling is good, knot security is good, but the reactivity is low. Now, therefore, the absorbable, then suture, the timing of the absorption, absorbable suture, the catgut, The plain catgut wound support is given for 7 to 10 days and complete absorption within 4 to 8 weeks. So that the tissue of subcutaneous tissue and its blood vessels, this can be used for that. But a chromic catgut, it takes 3 weeks for wound support and 8 to 12 weeks for complete absorption. So for vascular pedicles, vaginal wall, rectus sheath, this was being used for that. But nowadays we are almost eliminated, but still it is being used. I always also combine vehicle with the catgut also in many of these surgeries in the gynec and obstetrics. So delayed absorbable Dextran takes 3 weeks, vehicle takes 3 to 4 weeks, but complete absorption about 8 to 12 weeks, about 90 days. And that could be used subcuticular, facial structure, skin, and vicryl, particularly for vaginal vault, microsurgery, PDS for rectus sheath, and the uterine muscles for that. PDS, the rectus sheath and uterine muscles. And uterine muscles, I always recommend that the size is also important. Vicryl, whatever suture you use it, don't use more than 1/0. I think the whole volume of the suture is important for the tensile strength of the scar. So the scar integrity is dependent on the volume of the tissues. Less is the volume of the tissues, better is the scar. Even 1/0, you don't give 1/0, more than 1/0. 1/0 is enough for that. But 1, you can restrict it to the vaginal vault or to the rectus sheath. But rest with 1/0 vicryl, many things can be done, particularly for gynec and obstetrics. Vicryl rapide is one of the sutures particularly favorable for episiotomy or subcutaneous tissue because the complete absorption takes place between 5 to 6 weeks. You compare the vicryl with the vicryl rapide, the wound support will be in vicryl rapide will be a very short period, about 10 days, whereas the wound support in a case of vicryl would be 3 to 4 weeks, and the complete absorption occurs within 1 month in a case of vicryl rapide, whereas it takes 2 months, 90 days, particularly in a case of the vicryl. The non-absorbable are used in nylon, is commonly used for skin herniorrhaphy. Proline is for hernia repair and rectus sheath, particularly in weaker the abdomen, and silk for skin of the abdomen, ligation of internal iliac artery and other thing, we using it for that. Now, the other varieties, now the suture company has come out with the medicated sutures for that. So they say that you give a medicated suture and vicryl medicated is almost favored. I asked them one question. These are all unmedicated. These are all with septic suture and another is aseptic suture. Don't make it confusion, and this is a marketing gimmick for that. But remember, these are all sterilized, pre-sterilized suture. Just maintain it during the intraoperative period to maintain the sepsis, and then things will be okay for that. Now, then we come to the microsurgical instruments. Nowadays, when the IVF has come out in a big way, the results are very good, improved from 10% to almost around 40-50%. The incidence of microsurgical reversal has been reduced, but still we get some cases after tubectomy, tubal ligation, post laparoscopy or open with that. These are needs special instruments for that. These are small, delicate instruments along with the loop or along with the microsurgical microscope, operating microscope. The conventional instruments are these particular things. A smaller equipment, a small forceps, needle holder, and this is the uterus holding forceps. This is the cervix. This is not the uterus holding, it grips the cervix so that you can do a chromoperturbation. You can put a dye, installation dye in the fundus. So closure of the cervix, that is important. And these are all fine seizures and the needle holders specifically used for the microsurgical reversal. And this is usually the proline, which is being used as 60 or 80 proline, or you can use the vicryl also 60, 80, 60 vicryl can be used for that. So these are all microsurgical instruments which is there for microsurgical reversal of the tube, particularly following the tubectomy. So other basic conventional instruments, these are commonly be day in and day out. You must be using the cervical dilators, the curate, the punch biopsy forceps, Myama screw, HSG cannula, TOT needle, bulldog clamp, cat's paw, and uterine manipulator. Just a little bit of it. I will just show you the dilator. Just one thing on the Hager's dilator I can show, that here there are two varieties of Hager's dilator. One is on both ends, the two different sizes are there. On another side, on the left side, you can find a single-ended, only one. So, for example, and one is that on 0.5 apart, then 1 apart. So you give 3, 4, 5, 6. Instead of that, 3, 3.5, 4, 4.5. The smaller dimensions and unilateral are much more easier, much more used for hysteroscopy. So hysteroscopy doesn't need more of dilatation, and the too much of use of this dilator can injure the cervix as well as spoil it will form a gutter in the cavity, and if it touches the fundus, the hysteroscopy view will be different. And this is a sharp and blunt curate, again of the various types, is the basic requirement in the age-old instruments which you see that, and the single-ended and double-ended curate could be there of various sizes that is available for a biopsy. You use this curate for that along with the dilatation. So these are all important instruments which you can use it. Another important but common instruments which people don't bother about it is a towel clip. Towel clip is there, but the only thing you know that these towel clips are the purpose of draping, but the draping in such a way that the towel clip should not be exposed outside. It should be inward. You expose that so that it fixes with the draping, particularly for that. And this is what is known as a builder clamp, a very stout clamp, particularly for holding the cervix prior to abdominal vaginal hysterectomy. In a non-descent, when there is no descent, you can use this for that, holding the cervix. It's a very good instrument, and the grip is very good, and it doesn't clip it for that. And you can use it for myomectomy, for debulking procedures in a case of uterus. This also can be used as a supplement for that also, debulking. So these are all bulldog clamp. It could be straight, it could be little curved, and curved has a certain benefit also if the lateral part is visible. And this is all cat's paw of various designs. This cat's paw is there. Again, gives a very good, the claw gives a very good force, and particularly doesn't slip, and the grip is very good. And that's why for myomectomy and for debulking surgery, these are essential instruments for vaginal myomectomy or during vaginal hysterectomy. This again a good instrument which is already there. Myomoscope was earlier there. Now we are very commonly use it, particularly for myomectomy, for giving a traction, and even in holding the uterus, particularly when the uterus is not seen. Repeated surgery is there and you cannot see the uterus, only the fundus is seen. You, in the case of pelvic endometriosis, just put it the myomoscope on the portion visible on the uterus and give a traction and dissection. It serves a very good method for that, and the dimensions are also varying depending on the handle design to the tip. This is again an instrument, uterine manipulator. This is the uterine manipulator, the Shonawala manipulator. This has been called, and this is being used in a case of laparoscopy, with the diagnostic hysteroscopy, laparoscopy in an infertility, or in a case of hysterectomy also. On the other side, you find an HSG cannula, the Wilkinson cannula of various designs could be given, and that is helping for the diagnostic laparoscopy and chromopertubation for that. And this is the instrument which is used particularly for TOT operation, the TOT needle, which nowadays many of the companies come forward with that. And TOT from out to in, not from in to out. In to out, the Johnson has got disposable thing, which is very costly. And here it's a very cheaper instruments and reusable instruments. The right and left are different, and the different curvature. We do a TOT surgery with that. And with the eye, you introduce the tap, and that tap can be used particularly for the TOT surgery for that. And that's a very good thing for the stress incontinence, very common, very successful operation for stress incontinence. This is the catheter which I have already shown you about the Follis catheter and the Nilatans catheter. And this is the Nilatans catheter, which you see the single use and disposable polythene material by Jeromson, and this is all by the indwelling catheter by the Follis. So these are the two. It is a single time use, and this is for the indwelling purpose. Now coming to the fiber optic light source and instruments. These are fiber optic light source and instruments are used in all cases, particularly in structures where the inside you can see the visibility is poor, and particularly for speculum, for suction irrigation, for diverse, and these are the cases where this facilitates the vision for that. And you have an optical source and optic illumination and a cable which is available, connect it with the fiber and then demonstrate that. This is one of the cases where is a divorce attached with the fiber optic. This is a speculum. Here I have designed this particular thing. The speculum, earlier it was one end was there. I designed that, yes, you could have two ends. Here Here the ends, the bifurcate Y-shaped ends is there. One is on one side and another is on two sides. So this is how the fiber optic attachment is connected to the light source, and you can find the light source is there, and you can see the divorce and the deeper structures, how it can be seen very well for that. And same thing with the, you can detach, you can use it with the speculum. You can see there are two points, one on the right and one on the left, and the right side is at a higher level than the left, and so that the whole of the area can be seen. Earlier it was only one point. I told that yes, you make it Y-shape and make it two, so that we can see. And most important is the light source, particularly suction and light source. And this speculum, particularly with the light source, is helpful for visualizing the deeper structures in hysterectomy. After the doing uterus is out, you can see the deeper structures, and it's not a blind procedure for that. That is more advantageous for the fiber optic variety. And this is again a Youngquist light source, the suction with the light source, fiber optic light source. This can be used in abdominal surgery for that, but this could be a very long instruments, and instead of that, you could handle with the other designs of small handy instruments. And this handy instruments, I have designed that one side the connection will be there, the suction, and the other side the fiber optic light source, and about 2.5 centimeter from the tip the light comes, and that light is very, very good. And same thing, at the same time suction can be done, so that during the time of the deeper structures, when there is a bleeding source, and you can see the point design that the light is very well still, as well as the suction is there, so that you can identify where is the bleeding. That is the main advantage of it. And I use it, and I think it's a very invaluable instrument for vaginal surgery, for the difficult vaginal surgery, as well as for deep pelvic surgery for that. Now for obstetricians, two very important instruments. I'm not going to the destructive operations which have been obsolete now, and obstetric forceps and vacuum are the two indispensable till today. But the vacuum, there is a lot of changes in the design from Malmstrom, and till today we find a more commonly used the elastic vacuum. And the indication I always bear that apart from vaginal delivery, routinely I use the delivery of the head by cesarean section, use the vacuum for that. So that avoids the operative gymnastics for that. And coming to the forceps design, I think these are the forceps, three models: the low forceps, the mid forceps, cavity forceps, and the high forceps. Gone are the areas where the high and mid are obsolete nowadays, but still there is some place of forceps used, low forceps in vaginal delivery, as well as many people use it in the cesarean section, deliver the head in cesarean section. But the low forceps is there, and that continues for that, and still we are using it in some cases for vaginal delivery, and it could be an assisted birth, could be a vaginal delivery, could be there. But in vacuum, we have almost abolished this Malmstrom metallic vacuum, and instead we are very familiar with the this is Malmstrom metallic vacuum. This, because of the more of capsulomatoma and injury to the fetal head, it has been obsolete. Now the elastic vacuum and different shapes can be a very good option for that. And this is how we find that these are the elastic various designs could be there, and it fits very well with that. And the delivery of the head by cesarean or by vaginal route, this can be used. An extended indication of this can be used, particularly when you are doing an abdominal hysterectomy in a large myoma or a myomectomy in a large myoma. You can put this instead of the myoma screw, so that the unnecessary bleeding will not be there, and you can fit it with that and deliver the uterus, big uterus, employing this the vacuum, and this is very important for that. Now these are all, there are some instruments which are historical. This for namesakes we are using earlier, and people have devised. Bonnie's myomectomy clamp, one of the revolutionary. Bonnie was a father of myomectomy, and he has devised the myomectomy clamp to occlude the cervix and the vessels, uterine vessels for that. It's a very, nowadays, because of the inconvenience of the use and the alternatives like a vasopressin injection has come out, or the uterine tourniquet by simple number 10 fitting tube. This can be used an alternative, and therefore we are not using the one is myomectomy clamp. Uterus holding forceps, it's not necessary to hold the uterus. Either if the uterus is free, we can hold it with the two cockers, or if there is a lot of extensive adhesions, you cannot find it, put the Mahama screw in the parts which is visible and hold it and dissect it with that. Green hermitage, again, because it's a long instrument, 6 green hermitage on either side, you put it and apply it. Although the hemostasis is good, but the same thing can be taken over by atraumatic Ellis. 6 atraumatic Ellis can serve the better purpose than green hermitage, so that we have forgotten that. Ovar's self-returning speculum. It's very good because the heavy overt self-returning speculum, and it can be retaining very well as self-retaining. But I think it's not very well commonly used. It has caused a lot of, if it falls and falls on the surgeon's leg, foot, then you imagine the situation for that. And therefore, this is the alternative single-bladed speculum by the assistant can be of very good help for that. Vaginal self-returning retractors. I've used the lateral wall retractor of Giles, and I'm not very convenient on the, because it takes a lot of space occupying and all that, but it's not necessary. Just a temporary retraction by the assistant can help. I'll depend more on the assistant than the self-returning instruments for that. High obstetric forceps, as I've already told, except in the low forceps, high and mid cavity forceps have become obsolete nowadays for that. And same thing happens with the Malmstrom design of the metallic vacuum. Now Celastic has come in a big way, and Celastic is commonly being used. And what about catgut? Catgut is still used for that, and I think it has not gone to the graveyard, but it's a big question mark. Maybe that more and more of use of Vicryl can in future we see that catgut may not be available for that, but it has been certainly used as far as the cost is there, as far as the exposure, as far as the absorption. Earlier that superficial part, catgut is better than Vicryl, but Vicryl has become really very good as far as the tissue reaction is concerned, as far as the infection is concerned. Maybe that we have to forget the catgut for that. Now, tools for vaginal hysterectomy. I will just give a tools for vaginal. Commonly, we employ these few surgeries that I will highlight, the few surgeries in obstetrics and gynecology, and then end my episode for that. These are tools for vaginal hysterectomy. We do not require a dozen instruments for that. This is all in a one set we require. That is enough for the vaginal hysterectomy. That one, the sponge holding forceps for the draping, one needle holder, and 4 Ellis forceps, and 2-3 artery forceps, Spencerals artery forceps, and this is enough. And a hysterectomy set, and the knife, of course, the number 10 knife is important. These are all only the instruments that is required in vaginal hysterectomy. Don't crumble up the whole of the trolley with the all sorts of instruments. And in place, I have kept this one. You make it autoclave and open it at that time during OT. It's closed and you open it. And 10 instruments are very valuable for that and very dependable. One is a 2 double-bladed vaginal speculum, one on the posterior, another in the anterior part for that, and that you can see that. And then you require one, you require this instrument, which is Caesar, the Mayo Caesar dissecting Caesar for that, and this is important for the vaginal hysterectomy. Then this is the suction tube, where the suction, metallic suction, which is again a reusable. This is a bulldog clamp which holds the cervix. And then we have got this Mahama screw and the cat's paw. This is important where we want to debulk it, or in a case of myomectomy. And then these are 2 clamps which is there. And these 2 clamps are various, the different designs are there. The first clamp is that this is at last the needle holder. Everything, all these are enough. These 10 instruments are enough for the vaginal hysterectomy non-descent. And the clamp which you see here, one is a little curved. The upper pedicle is used with that. Or if you want to have a removal of the ovary, then you can use this upper bent clamp, so that these can be used in upper pedicle or infundibular pelvic for that. So these, for these 10 instruments is enough. Don't jumble up the instrument in a case of vaginal hysterectomy. And this is, I have not designed that, but at least customized in one known as a vaginal hysterectomy set. So with that set, the companies are marketing this, and this is not only a good thing, but the instrument quality is also very good. And I always tell that make the quality of the instruments very good, at least the clamp and all that. If clamp slips, imagine the situation of the surgeons. This is the clamp which I was telling. There's a little cord clamp. It is not like series set clamp, but this design is just to have a both purpose in the upper pedicle as well as for the infundibulum pelvic. So these 10 instruments along with the 4 LEs and 2 artery forceps with the scalpel blade, this is enough for a surgery. And one more thing you require, if you are going for a sutureless hysterectomy, don't have a suture. With the suture, if you are using a suture, that is enough. If you are using a sutureless, you use a Mark clamp of Martin or Alliance varieties of the bivessel, the vessel sealer, connect it to the vessel sealer, the electrosurgical device, and do the sutureless varieties without the suture. And at the last, you have to one suture is the vault fixation. After that, even if you're using the bipolar vessel sealing system of whatever design is suitable to you, you have to fix the vault on the 2 ends and suture it to close the vault, leaving beside the middle part for that. So that is the basic requirement of tool for a vaginal hysterectomy for that. Therefore, the power in surgery, those who are using this vessel sealer, they are new generation of multifunctional adaptive generators. On the left side, I've seen the Alan, our own indigenous varieties. On the other side, the Martin, there are various types. The Well Lab is there. The other power sources is there. And believe me, this is a composite multifunctional system. Monopolar, bipolar, vessel sealer, as well as underwater cautery. Everything is there with you. So with one instrument, you can use in all varieties of surgery for that. If you're going for the open laparotomy, the monopolar can be done for that. If you're going for the vaginal hysterectomy or abdominal hysterectomy, sutureless, you can use it, the vessel sealer for that. If you're using for hysteroscopic surgery, you can use the underwater cautery, and with the same machine, it can deliver all the goods. And it's a new generation of multifunctional adaptive generators. And it is auto sensing mechanism is there. And with these 2 instruments, you can connect it with the hand instruments. On the right side, this is a Mark clamp, and this is a pistol set which I designed with the Martin people. A very cute instrument which I always use for the last 10 years. I'm using this particular instrument, both cutting, the coagulation and cutting. So this is only coagulation, and it's not a cutting device is there, but here is a cutting and coagulation. So you just but the length is small. It is a very useful instrument for abdominal surgery. And this time the thumb, you have a presser, we have a PowerPoint, and you press it and then it will cut a mechanical cutter. So that is very helpful for me, particularly for abdominal surgery, as well as for malignancy, ovarian malignancy, birthing, everything that we can do. Even vaginal hysterectomy, we can do it with that, the single thing without a cutting for that. This again, Alan's, the cheaper variety, and this is shear. This is shear, the tip cuts it. So you clamp it, coagulation with the whole of the clamp, and the tip cuts it. It's a very cheaper instruments which can be used particularly for hysterectomy and electrosurgery and sutureless varieties. If you are not using suture, these are some of the hand instruments when you can use it. It is plentifully available. It's very economical. India genius is indigenous, that Indian people are there. But the Martin is also, I'm very happy with the Martin, where this design is yet to be marketed. And I've told that this is very useful for that, very handy, and I use it's a very favorite instrument of mine for that. Now, tools for cesarean section. Let's say, for example, take one case, a common instrument. These are the instruments, at least whole of the instrument in one trolley with the cesarean. You don't require much of the instruments. One sponge holding forceps, one scalpel, blade and scalpel, particularly 10 or 20, and 6 Ellis forceps, 4 artery forceps, 1 or 2 tissue forceps, these towel clips, 4 muffs, not more than 4 muffs in one cesarean. You take it 4 muffs maximum, because we use more of suction than the mopping for that. And these are all atraumatic Ellis, which can be used both for the rectus sheath as well as for the holding the peritoneum and as well as the uterine wall. So these can be helpful for that. And the artery forceps can be helpful for holding the peritoneum, and some of the twigs can be coagulated with the tweezer which are using it. This is used as a cutting, soft cutter can be used, or you can use the blade and then cut it. These are all tooth forceps, the tissue forceps, and the two dissect through seizures, Mayo seizures, and one thread cutting seizure. That is a separate thing which must use it, and one Doyne's retractor to retract the bladder. I think this is enough. And for the deliver the baby, again I am told that yes, the vacuum, the conventional vacuum, elastic vacuum, this solves whole of the purpose of cesarean section. You don't overcrowd the trolley with all these, and this is a suction which can be used, the disposable or reusable, whatever it may be. You can use this particular thing for that. And of course the cord clamp to artery forceps, and of course the needle holder with the seizure with the needle. And this carb needle holder is absolutely very good for that. So this is a tool for cesarean section. Don't overcrowd it with the instruments, jumble it with the instruments of different packs for that. It's not necessary. Of course, the Follis catheter, at the end you can give it for that. Now coming to the endoscopic tools. Gynec endoscopic equipment, hysteroscopy and laparoscopy. We want these two mainly. I will focus attention on hysteroscopy and laparoscopy. I've divided into 4 different varieties of instruments or equipments. There are first category is a basic electronic. Second category is a basic non-electronic. Third category is hand instruments. And fourth category is ancillary conventional instruments. These are the 4 different varieties for that. And basic electronic, you have got a carbon dioxide insufflator, a light source with cable, a camera, endomat, and a morcellator. These are all basic electronic equipment. Carbon dioxide insufflator. Insufflator is a machine which delivers the gas, particularly the carbon dioxide, in a desired manner. And that could be auto stop. You fix it at 12 to 14, it will stop it. And carbon dioxide insufflator is a very valuable instrument for in the pneumoperitoneum. And this is all basic electronic, one of the basic requirements for laparoscopy. Now coming to the light source with cable, there are various types of light source: halogen, halide, xenon, and LED. And earlier we are using a lot of halogen light, but it's not a white light, and therefore the xenon light is very much favored for that. It brings a good light source and a white light. But the problem of the xenon is that the xenon lamps has to be used. Maximum, the xenon 300 we use it, and it is used for 400 hours maximum. And the cost of replacement, again, it will charge more than recurring expenses. So LED also is a better light source, and the duration is much more better for that. So light source with cable, the LED is absolutely number 1. And halide is a very poor but cheaper light source which are not being used. Halogen is not being used. Xenon and LED is the choice for that. Now coming to the camera, it has gone a lot of revolution. Endoscopic, when we have used with the analog camera with a single chip, and then come the triple chip analog. Then the digital technology came, and digital, the image one came and get a revolution on the vision quality for that. And then after the digital, the HD, the high definition camera has become a very good thing, because the vision is important in a case of laparoscopic surgery. If the vision is not good, you cannot do a good quality surgery for that. And now the 3D. The 3D is absolutely, earlier we were thinking that 3D is a luxury, but now I feel that 3D is not luxury, it is an essential thing, particularly for some cases like a myomectomy, endometriosis, or a difficult surgery, difficult pelvic adhesions, and oncosurgery. These are all very, very important. 3D vision is important. And now 4K also is equivalently good. And 4K is a big screen is there, the quality of vision is there. So we have gone a tremendous advances in the vision, particularly from analog to digital to triple chip to HD to 3D and 4K. I do not know in next what is the situation next henceforward for the camera, but this has a real advancement in the basic electronic gadgets, particularly for laparoscopy and hysteroscopy. Then endomat. Endomat is nothing but a suction irrigation device in a very controlled method, electronically monitored suction and irrigation device. And that is very useful, particularly for hysteroscopy, both in a diagnostic as well as in an operative. More so in operative, because you can control it. The absorption is not much, so that the toxicity of fluid overload will not be there with that. So endomat is a very good equipment for that. And along with the hysteroscopy, this endomat can be also used in laparoscopy. How the laparoscope, there are two sensors there. You use the hysteroscopic sensor, the hysteroscope will come. Use the laparoscopic sensor, laparoscope will come. So laparoscopy, we can use the suction irrigation also, and aqua dissection. All this can be better managed with the same instruments of endomet for that. And of course, the controversy about the power morcellator, which we use it in India, still law still law permits us to use the morcellator. Only the one case in United States has really chunked whole of the world regarding the use of morcellator, and Johnson and other people have stopped morcellator. Even starch, people are thinking of abolishing the morcellator, but starch morcellator we are still using till date, and it's very good. Rotocort is a very good morcellator which are being used, and this is a basic requirement. Whatever it may be, Einberg morcellator, whatever it may be, it's not very convenient. And of course, the how many cases of leoma, sarcoma you get it, you just earlier screen it before the surgery, and if there is a thing that you have screened it, I don't feel that morcellator is to be banned for that, and we are using it. Then this is one of the basic electronic gadgets, particularly for laparoscopic surgery. And basic non-electronic, what are the basic non-electronic? First of all, pneumoperitoneum varus needle is a basic non-electronic. Trocars is a basic non-electronics. Hysteroscopic sheath, both diagnostic and operative, basic non-electronic. And of course, for hysteroscopic surgery, resectoscope is a basic non-electronic equipment for that. So you divide into basic electronic, basic non-electronic, and then hand instruments. Hand instruments, in hysteroscopic hand instruments, we use grasper, scissors, morcellator, cannulation catheter. And in laparoscopic hand instruments, there are varieties of laparoscopic hand instruments, but we select very few, those required in particular cases, like scissor, dissector, grasper, both tooth and traumatic, suction irrigation cannula, bipolar vessel sealers, shears, harmonic, high frequency needle for PCOD, LOD, needle, only needle for injection of vasopressin, hook and spatula for coagulation and cutting, and myoma separator and screw for myomectomy, tenaculum to hold the myoma, and needle holders to suture it. So these are some of the basic hand instruments which require. Don't put all the hand instruments in one surgery. Depending on the cases, you shine it for that. So these are histolaparoscopy hand instruments, varus needle and trocars. So this is the varus needle. The Janus varus first used it in a case of the tuberculosis, in making that this simple concept of a needle, introduced it into the chest wall. And therefore, we say that laparoscopy, Jacobi has found that yes, in laparoscopy also we can use it, and as soon as it goes inside the pressure, the blunt end comes, and therefore it doesn't cause injury. There are two varieties. Varus for pneumoperitoneum is the other. Another varus is a stouter and is a longer, about 12 centimeter, about 18 centimeter length. Then that is a longer instrument. It can be used as a manipulator also. Instead of a second port, we can use this as a manipulator also. And this varus, conventional varus, is very good, particularly for pneumoperitoneum. You can use a direct entry also. Many surgeons are using it. And these are all trocars. These are all various types of trocars. The shape also, the diameter also varies. This is number 10, this is number 7, and this is number 5. And these color-coded, Starch has color-coded these particular varieties. This yellow variety is number 7, black variety is number 5, and the green variety is number 10. And these are all 5, black variety, black type, and this is the trocar. This is a sharp trocar inside, and there. And the other one is a safety trocar. Instead of the sharp, we have a safety trocar. Here you can see the safety trocar. We use it, commonly use that. And for diagnostic histolaparoscopy, no more 10 millimeter, we're using it. We're using this 5 millimeter is enough. And because of the camera, is the high definition camera which is there, and just intraumbilical, don't make a separate incision. Intraumbilical, you insert the 5 millimeter with the 5 millimeter telescope, and preferably use this atraumatic and safety. I think trocar is very good for that. And these are all telescopes. The telescope designs and the various the laparoscopy and hysteroscopy, both are different. They commonly for laparoscopy, we usually commonly either a 5 millimeter, 7 millimeter, or 10 millimeter. 10 millimeter is only for 3D, but 10 we are not using. I am not in favor of using the 10 millimeter in all cases. The 5 millimeter can be very well used, particularly for all types of surgery, and you can use the 7 millimeter also for that. And the tip, either it can use the 0 degree, this is 0 degree, or you can use the 30 degree for that. And this is the 30 degree 5 millimeter telescope. This is the 0 degree 5 millimeter telescope. So this can be used both for laparoscopic surgery, for putting a 5 millimeter trocar, and then use the all types of surgery, provided the camera is very good. You are using the HD camera for that. And these are the smaller equipment. These are all the hysteroscopic telescope, where the tip is 0 degree is only for the contact hysteroscopy. But this is all either 12 degree or 30 degree. Commonly, we use the 30 degree, and for visualization of both the ostium. And this is there are two types. One is 3 types of telescope are there, depending on the type: 4 millimeter, 2.9, and 1.9. So lesser is the diameter, better is that you can, without dilatation, you can do it for that. But the risk is that the maintenance of the equipment is a too, I think, slender instruments, smaller, thinner instruments, they're more likely to break. So commonly the 4 millimeter and 2.9. This is a 2.9 millimeter, which is used for that, and the diagnostic sheath, the outer sheath, and the inner sheath, and water comes from below, light from above, and that is fitted with that. Clockwise direction is locking, unlock, anti-clockwise is unlocking for that. So like that, you assemble the instrument, the sheath, and this sheath is used particularly for diagnostic purpose for that. And you can double channel sheath is much better because the visibility is very good. Single channel you can use it because to avoid the dimension, and this is about a smaller dimension, about 2.9 millimeter telescope, and again a double channel, which maximum it can give to 4 millimeter. So 4 to 4.5 millimeter total, including the sheath, can deliver the same view, provided you have got the good camera for that. So this is mainly used for diagnostic hysteroscopy. These are the telescope which can use it, and this telescope can be used for operative also, because the hand instruments again are of different varieties. Now for hysteroscopic surgery, I will show you the hand instruments. These are all 2 hysteroscopic surgery. One is operative sheath on the left side, and another is the resectoscope on the right side. And these are some of the malleable, semi-malleable, metallic operative instruments. And these instruments, either a scissor or a grasper or a morcellator, or you can use the tubal cannulation catheter. So this is a separate channel which is there. You can introduce this separate channel along with the inflow and outflow, and in the center you can use the camera for that. You can see these are the grasper which is used for that, to hold the grasper. Say for example, the commonest is the lost IUCD. You hold it on the vision and just bring it for that. And scissor, you can use it, the cutting a small synechia, or you can go, a septum also can be used, deal with that. And that is essential without a current for that. And of course, you can use this commonly used proximal tubal block. This is the tubal cannulation catheter, which is indigenous Indian. Earlier we were using the novice thing, but here we can use this and introduce that. And there is a stellate there, and you remove the stellate, introduce the Teflon catheter, and go and cannulate under the vision for that. So these are all operative sheath for that. And of course, the his resectoscope is used where the current is there, and you can use the current, you can use the loop, you can use the Collins knife, particularly for septum resection, or for myoma resection, you can use the loop. And the wear loop is a very good instrument for that. And the resectoscope is a very invaluable instrument for hysteroscopic surgery for that. And this can be bipolar or unipolar, and the unipolar can be better used particularly for glycine. If you're using the glycine, the unipolar is used. Otherwise, nowadays we have shifted from unipolar to bipolar, and the bipolar, these are all loop. which is there for myoma resection or the endometrial resection for that. And these are resectoscope where you can fit it with that. The initial resectoscope, you can load it with the appropriate instrument, and then you can use it particularly for the resectoscope, and by current, you can use that. And this monopolar, you are using the glycine, but in bipolar, you are using the normal saline. And this is the current where it goes that, and with the active and passive movement, you deliver it. Active movement from below up is a septum resection, but passive movement from up down, from above down, is a myoma resection. This is the basic difference in the two types of movement in a case of resectoscope or hysteroscopic surgery for that. Now, these are some of the instruments assembled for the hysteroscopic laparoscopic surgery. And apart from it, the ancillary instruments like a speculum, the dilator, the Ellis, the curate, these are all essential for that. And ancillary instruments, the conventional instruments, are essential. And apart from it, the basic hand instruments, as I have already told, this can be demonstrated and used it for that. And these are all sheaths. These are all telescope, the hysteroscopic telescope, the operative sheath, and the cannula, the cannulation catheter. So these for hysteroscopic surgery or for diagnostic, you can use the sheath only, but for operative hysteroscopy, either you can use the operative sheath according to the purpose for which it is used, or you can use the resectoscope as demonstrated here. So whole set, this is only one set of hysteroscopy, both diagnostic as well as the operative hysteroscopic surgery. On the left side, you can see the resectoscope, and this is the resectoscope. These are the components of the resectoscope, 3 components of the resectoscope. On the right side, the conventional small instruments which is used for that. And you can use without this also with the vaginoscopic approach. And vaginoscopic approach, you can do diagnostic, but for operative procedure, you have to do dilatation a little more. And for that, the dilator is necessary. And you can dilate up to 10, 12, and then do the surgery, whatever is possible for that. And that is the hysteroscopic instruments, which is hand instruments, which is required for that. These are all basic non-electronic equipment that is required. And I have already shown this particular sheath, the outer sheath and the inner sheath, is our double channel, gives a lot of clarity and vision in during hysteroscopic surgery for that. So although the single channel sheath is available, the single channel sheath, the only advantage is that the minimum dilatation is there. A little more dilatation is there when you're using. But if you're using the 2.9 lesser dimensions of the telescope with 4 millimeter also, total diameter of 4 millimeter, you can do all the surgical procedures also, because the resectoscope also carries the smaller dimensions, and they can do that for that. But these are the cases where this needs an attention for that. And the cable, attachable cable, and very gently you must assemble it. And you see the 2 markings on either side, and 2 markings and the cable on one position. You keep it, and then only it will lock. Otherwise, it won't lock. The 2 marking you can find, and then you can lock it. The clockwise is locking, anti-clockwise is just unlocking it and removing the telescope for that. So these are all locking and unlocking gives rise to this procedure, and you unlock it, and then very gently you just introduce your telescope, because smaller dimensions of telescope are very delicate to handle. And the tip, you find that these are all 30° 4 oblique. That means if you're using it, the one side, if you're using on the right side of the cable, the left ostium is visible. Left side you twist it, the right ostium is visible. And that's why you can do the job for that. That is the importance of a panoramic hysteroscopy rather than the contact hysteroscopy. Contact hysteroscope has got a 0°, and 0° has a lot of inconvenience, particularly for the hysteroscopic diagnosis and operative procedure for that. And this I've already demonstrated about the operative sheath. There is a separate operative channel which is there, and through that channel you introduce your hand instruments like the grasper, like the scissor, or the cannulation catheter for that, and complete the procedure with that. That completes the hysteroscopic surgery, both the diagnostic as well as the operative procedure for that. When you combine hysteroscopy and laparoscopy, I have already told that in addition, you require a telescope, 5 millimeter telescope, and a port and Veris needle, and then some requirements for the chromoperturbation. The HSG cannula is required, and the chromoperturbation can be done in the diagnostic sitting. Both hysteroscopy and laparoscopy. DHL has become a very important and integral investigations for the infertility patient. Of course, these invasive investigations, don't do it routinely in all cases, but at least in cases where it is required, you can do it. And according to the pathology, you can do some of the surgeries. The commonest pathology, we find that the septum, you must do it the hysteroscopically, the myoma, the polyp, the cannula, proximal tubal block, the removal of the foreign bodies. These are all very common surgeries which can be done apart from taking a biopsy and a diagnostic, particularly for abnormal uterine bleeding or synechia or infertility evaluation to see the interior of the uterine cavity for that. And this I've already told that this is a cannulation catheter, which is cheaper in comparison to the novice variety. And this novice variety is costly. And this is the classical resectoscope. This is a bipolar resectoscope. The bipolar resectoscope is completely different than the monopolar resectoscope. And the bipolar resectoscope had an advantage that it can be used, the same components are same. The three components are there, the inner, outer, sheath, and the resectoscope. And only thing is that the bipolar resectoscope needs a normal saline as a medium in comparison to the glycine as a medium, where the glycine toxicity is there. But still, you must be very careful that the deficit has to be taken into account. In a monopolar, the glycine, when you're using it, at least 750 ml deficit, you must be cautious and abandon the procedure if it is more than 1 liter. Whereas in a normal saline, you use up to about 2.5 liters, then abandon the procedure for that. And because that is not going to produce ammonia toxicity, but they can produce an acute pulmonary edema because of the fluid overload for that. So that is the difference in that, particularly the complications, how to avoid it. And this is how you load the Collins knife or the loop, and this is how you load it first and then clip it, and then subsequently introduce the inner channel, then outer channel, and lock it, and then attach the cable, and then do the procedure. And as I have already told, this is the active movement and this is the passive movement. Active from below up and passive from up down. And these are the assembling of the resectoscope in hysteroscopic, operative hysteroscopy for that. So this is a very rewarding surgery, particularly for many indications where the tools are absolutely important for that. Unless you see clearly the interior of the uterus, it can't see. And these are the basic electronic equipment which I've already showed. Again, I will show this is important. And HAMU endomat. Endomat, the hysteroscopic sensor and laparoscopic sensor being used. The first one is the ml. How much ml of fluid can be delivered? You adjust it at that level, whether up to about 500 ml can be there for that. And this is second part is a millimeter of mercury. Normally, you don't raise up to 150. Maximum, it is told that 80 millimeter is absolutely normal, but 80 millimeter intrauterine pressure is not maintained. Some leakage is there. So 100 to 150 millimeter mercury, we use it. And here the 300 ml per minute. And the suction, this is the third one is suction. You just don't use more of suction. 0.1, the lowest suction, otherwise you can't see this collapse of the uterus with cavity will be there. And these are all, this is second is electronic endoflatter. This is a light source and this is camera. And camera, Image1S HD camera, and 3D is also available. This light source is a xenon light source. You can increase or decrease the volume, the intensity of the light source. This is a light source with the cable, and the fiber optic cable can deliver it because it's a cool light source. And the extreme left is the insufflator, which you find it. And here the camera, the monitor, and that completes the electronic gadgets for that. And for hysteroscopy, this is essential. We don't require an insufflator, but at least a HAMU endomat is necessary. Light source is necessary. Camera is necessary for that. Now, laparoscopic hand instruments. What are the laparoscopic hand? These are all varieties of laparoscopic hand instruments I've displayed for your benefit, and whole lot. And all the laparoscopic instruments are not required. particularly for all cases. Don't jumble up all these equipments in one trolley for that. That from the beginning I'm telling you. But to show you what are the requirements which is for gynecology, in total gynecology, we require a needle in some cases for injection of the vasopressin or injection of the needle. Then this is a spatula where you can coagulate it, the monopolar coagulation, the spatula, or cut it with that also, the spatula. And this is a hook. This is a monopolar hook. You can also give an incision on the tissues for that. And the hook, right angle 90 degree. And this is a high frequency needle, mainly used for the drilling, LOD. So just for description, for elaborating all the equipment that is required, hence you do it. But don't display all the equipment. According to the diagnosis, according to the surgery, you just display this one. Hardly 3-4 equipments, hand instruments are required for that. And this is a atraumatic grasper, grasping forceps, atraumatic grasper. These are all detachable hand instruments of starch. You can use it with the local thing also. There is no problem for that. And this is a tooth grasper, in comparison to the atraumatic grasper for that. And this one is a carb dissector. And this dissection is important, and carb dissector is also a very valuable instrument for dissection. Carb dissector, and this is one. And this is a scissor which can be used. This is a reusable scissor, and we are using more of reusable instruments than disposable instruments for that scissor. And this one is again an instrument, a Babcock. Babcock design is not always necessary for that, but rarely you can use it with the if you are using the bowel, you are using the vital structures, you can use that for that. And this one is again a atraumatic grasper. Atraumatic grasper is a long grasper when the tissues can be grasped in a bulk. So in comparison to the earlier grasper, it is a longer diameter, the length is more. And this is again a bowel grasper. Bowel grasper, the length is more, and atraumatic, absolutely atraumatic for that. And this is important. And this is a tenaculum, which is used particularly for the myomectomy, to hold the myoma and then separate it for that. So myomectomy, this is a tenaculum which can be used for that. And these are all the myomectomy is an invaluable instrument for that. We can use the myoma screw in place of that. But believe me, this tenaculum is much more better than the myoma screw, because you have to screw and different places for that. And this is causes a lot of injury for that. And this is again a very valuable instrument, a suction irrigation cannula. And suction irrigation cannula can be helpful for a dissector also. And it's a very invaluable finding for pelvic surgery and for gynecological laparoscopic surgery. All varieties, this is important for that. And this is the myoma screw, which I was showing. The myoma screw or tenaculum can be used either in a case of myomectomy for that, but you grasp it with that. But another equipment is very important. It's a myoma separator. It's an indigenous Indian, and therefore indigenous, and therefore this is a myoma screw. You can separate it, myoma separator. So you can dissect it, you can hold it with the myoma screw or with the tenaculum and separate it with that. And that is at last is the needle holder. It's a very stout needle holder, which is grip and the long and carved at the end. And this is a very good equipment for suturing, and the suturing, and particularly for the myomectomy and any type of suturing, this can be used for that. And this is a port closure needle. And I have already told about this port closure. There are two types of needle here. Earlier we are using this port closure needle, and we're using it, introducing it, and that. But this latter design, this design is much more superior than this design, and the less injury will be there. And the very simple concept of a spring-loaded device, and the spring, when it pushes it, then you catch hold of the suture. Then the needle will come. You with the needle, you introduce it, and on revision you can just remove it. And that's a very good equipment, port closure needle. You can give it for that. U-turn manipulator. U-turn manipulator. These are some of the U-turn manipulator. The commonest, we see that the commonest manipulator, we use it. This manipulator, we use it. But in case of hysterectomy, in a case of total laparoscopic hysterectomy, this vaginal tube along with the manipulator is being used. This is a simple design of vaginal tube with the manipulator that can be used in comparison to this manipulator. So this manipulator, a good manipulator can move it in all directions for that, and therefore this is important. You can see that this manipulator, and originally when I've used this manipulator earlier, where there's a ceramic tip at that level where the colpotomy has to be given, and then, but it is a very long instrument. They were designed by Starch. A simple, cute instrument. I think these are much more better with that. And this is also another type of manipulator which you can use it, and disposable thing can be used it for that. And this is the vaginal tube, which can be which is being used, and the tip here you can see the tip is flat, and you can see while introducing you make it like that, and when it touches the fundus it is the right angle, turning 90 degree with that, and then the perforation chances are not there because it's a transverse these touches, and 90 degree it can be there with that. And this is a Clamofran variety of manipulator. With that, we have almost abandoned this manipulator and using this for the TLH. You see the bend is there 90 degree, and that will absolutely by giving it straight, and then you can introduce this with that. Otherwise, the tube, the vaginal tube, particularly for hysterectomy, and this is a conventional uterine manipulator. This also can be used, but colpotomizer can be an aided thing for the last step in that particular. You can manipulate it, but the last step of colpotomy, the making an incision on that vagina, that is very good for that. And this vaginal tube can be only held it for again a colpotomizer for that without a manipulator. This is with manipulator colpotomizer, and that is without manipulator colpotomizer for that. So instruments for diagnostic histolaparoscopy, again, I can say that along with the few common instruments like a sim speculum and Ellis forceps or uterine the cervix holding forceps, like a tenaculum, you can use it, and then the other instruments, the hand instruments, you can use it. Select the instruments, very few instruments you need it, and normally we don't require much of instruments for that. One port, at best 2 ports are required. One hysteroscopic diagnostic seed is required. One 5mm laparoscopic telescope is required, and then a chromoperturbation thing is required for that, and that is enough for a diagnostic histolaparoscopy, along with the methylene blue for the chromoperturbation for that. And these are instruments for lap surgery. These are instruments for lap surgery where you require a more number of instruments. A trocar number is more. You can use the 10, you can use the 5, 7, or 2 5mm and 1 10mm is enough for that. Maximum 3 ports are there for that. So this is again a laparoscopic surgery. In general, we can use it particularly for that. And here in laparoscopic surgery, electronic endoflutter is absolutely important. So electronic endoflutter, you can see a little bit about it. This is the millimeter of mercury, the intraperitoneal pressure. You set it at 12 or 14, and this is the liters per minute. The middle part is the liters per minute the gas comes, and you can increase or decrease it. But while using the varies, the maximum, if you increase it also to 5, 6, it cannot go more than 3 liters per minute. But in a trocar, whatever adjustment has to be done, it is done. You use a more of suction, means more higher level of the gas is required for that. Liters per minute should be there. So in that case, you make it high, about 8 to 10 liters per minute. Here is a 20 liters maximum electronic endoflutter. The highest is it can deliver it 20 liters per minute. So you can adjust it accordingly. And this is the electronic endoflutter. On the back side, you find a carbon dioxide has to be used for that. If you're using, this is the gas which is connected to the posterior aspect. With that, I'm using the carbon dioxide cylinder from below in my central store and connecting it with the gas pipeline. but you can use the cylinder also with that. If the cylinder is not, if a gas pipeline is not available, you can use the cylinder. And this I have already shown about the xenon light source. You have to increase or decrease it, and the medium light source according to the requirement, you increase or decrease the light source for that. And I've already told about the Hamu endomat, which can use it, and the left side you can see the unit drive or the morcellator. I will show that the morcellator. This one is Hamu endomat, where I've already shown in the extreme left is the pressure, is the fluid, and then the pressure, and then the vacuum, the gas, the outlet, and then the unit drive is a rotocot morcellator, is a unique morcellator which is being used today also, and all of us are using it. But we do a routine pre-op assessment and then use the rotocot morcellator for that. And for that rotocot morcellator, the hand instruments, the basic electronic equipment is a unit drive connected to the hand instruments of the morcellator, and then rotate it, and then you can do the job for that. And you see that majority of the cases of myoma or tissues with a large bulk that is not being delivered through the pouch of Douglas. If the pouch of Douglas is clean, yes, you can deliver it through that. But majority of the cases is associated with the endometriosis, and POD is obliterated, so that you cannot perform the procedure and retrieve the tissues with that. So I feel that majority of the cases will require this removal by the morcellator for that. And this is the morcellator, rotocot morcellator, the assembly, which I will show you. Just this is a unit drive machine which is there, and this is the basic electronic equipment for the rotocot morcellator, where it is connected to the this is a motor which is there, and this you introduce, assemble it to the proper way, the blades. This is the blade which is there inside, and then the 10 millimeter grasper is introduced with that, which is grasping that like a tenaculum, and then hold it with that, and then the power, the pedal switch is there. You press that, and you can see the movement of you can see clearly the movement of the blade, and the movement of the blade can see that yes, it will go in a clockwise or in an anti-clockwise direction, and can deliver the tissues and retrieve the tissues for that. So this is the purpose for which I wanted to show the importance of the morcellator, which is very, very important for. So these are all assembled in a pendant, and this pendant can help you for the space in the OT for that. And for laparoscopic surgery, you don't require all the instruments for that. At least few instruments are necessary. The hand instruments, which is mainly necessary, is a dissecting forceps, a suction irrigation cannula, is a grasper, tooth grasper, and the atraumatic grasper, and vessel sealer, and the coagulation thing system, like electrosurgical device, like a Marlap or a shear. This is important. This is a Marlap of design, and this is very good as a vessel sealer for that bipolar. And this is another instruments which is really a very traumatic instrument for that, but don't require all the instruments at a stretch for that. Depending on the procedure, you use it and then complete the procedure. This is one of the harmonic harmonic blade which is being used, and that can be used as a power source for that also. And these are all instruments which I have already shown you earlier, but don't use everything with that. With 4 or 5 instruments, you can do everything, almost in a job. And depending on the surgery, don't crowd the overcrowd the trolley with all the hand instruments that you have it. But basically, you remember there are 2 trolleys. You make it 1 trolley for the hand instruments and 1 trolley for the telescope and other valuable instruments for that also. So don't put it in 1 trolley. Make 2 trolleys in a laparoscopic, even if it's a surgery of say cystectomy or ectopic, or even the radical procedure for that also. This is how you assemble and deassemble the procedure. You remove it. The three pieces are there, and this is the insert which is there. This is the outer sheath. This is the sheath and insert, and just introduce it and have a anti-clockwise direction. It will lock it, and then just straighten it up and push it here, and this is how you lock the instrument for that. So you have to change it. You can change the insert, you can change the handle, or you can change the sheath. There are three options are there for this procedure for that. So these are all instruments which is very important. I've already shown you all these instruments again for the laparoscopy surgery, but again I'm telling you that you choose the instruments on which surgery you are going to do that and apply that procedure for that. And the power source, you can use it with the MATLAB, or you can use it with the shear, or with we can use it with the harmonic, depending on the procedure. There are many people who are very familiar with the harmonic. They use only the harmonic. Harmonic has an advantage that the lateral spread is least, the thermal damage is least, and if there are gut adherent to that, I think the harmonic is much more preferable than the electrosurgical device like a shear or a bipolar vessel sealer for that also. So that is the advantage of harmonic. But at the same time, the harmonic has a demerit of the vessel sealing. Vessel sealing capacity is not inferior to the bipolar. And of course, you have to reduce the power setting from 3 to 5 to 1 to 2, but still it takes really the coagulation. In addition, you need to apply the vessel sealer for that. So these are some of the instruments. If you are going for only LOD, just remove that only LOD, only grasper, automatic grasper, and LOD needle, and suction irrigation cannula is enough for that. So don't crumble. And this is a harmonic, which harmonic shear. The cost is there because it's a reusable. It's not a reusable, it's a disposable equipment. And the harmonic one blade costs a heavy amount for that also, almost around 40,000, more than 40,000 rupees. And that can be used for 10 to 12 cases for that. So these are all instruments for laparoscopic surgery, which I'm again showing you the whole list of hand instruments in the displayed in the trolley for that. But again, I'm telling that don't use everything into it. Depending on the indications of the surgery, you can use these instruments for laparoscopic surgery. So this is all about the endoscopic gadgets available for that, and your expertise is necessary to choose it and to handle it and do the ultimately good quality surgery at the end of the job. Procedure and almost result. It always remains about the result for that. Now, coming to the future, third, I've already told about the conventional, I've already told about the hysteroscopic surgery, about the laparoscopic surgery, and the ancillary conventional hand instrument, which is used in combination with the endoscopic procedure. And now coming to the future, what is left in the future? Now I see that it could be a fantasy and it could be an innovation from that. We have come from knife to chip, from macro to nano, from analog to digital, from physical to remote surgeries, like a telesurgeries, from crowded OT to lonely OT. There are no persons. You just have a voice controlled, you just have a dictum and then do it in there. And from human intelligence to artificial intelligence. When artificial intelligence will be employed, even what will be the fate of the surgeons, classical surgeons for that. Now, implications on the development of art and science of surgery in future would be advances in robotics, virtual reality, digitalization, telesurgery, simulation, and of course, artificial intelligence. These are all components which is there. This seems very good. Digitalization, now we have come to the digitalized world. We have lost touch in human touch. We have only digitalized medium by WhatsApp, by laptop, by everything. Today, this is an example which I have shown the demerits of digitalization. Today, I have to break it for 10 to 15 minutes because it requires update, automatic update for that, and my laptop completely gone out for that. And you was, I think I was disturbed and I was away from you and for about 12 minutes for that. And this is the demerits of that. Everything cannot be just that everything is good. And this is the demerit of digitalization for that. And also, we are also defective that we are not up to date in that. updates for that. We are behind that. So future is the age of information, fundamental change from tissue to instruments, tissue and instruments to information energy, from objects and atoms to bits and bytes, and from macro to nano, and from classical knife to chip technology for that. And same patients also changing. The future generation of patients also will change. They want it, arrives in the office or from home. They want infinite amount of time from you. They want instant diagnosis, immediate treatment, no complications, pleasurable surgery, and leaves your hospital with 200% cure rate. It is only possible when the physician or the surgeon will be a superhero or a miracle healer. Otherwise, this cannot be meet the requirement of the patient's need. Sir Robert Hutchinson has told, from the inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, treating patients as cases, from making the cure of the disease more grievous than endurance of the same. Good Lord, deliver us. And Tillian, I again repeat this Tillian statement. Today's innovations are tomorrow's history. Don't boast that we have done it, and don't criticize the previous generations of the surgeons that they are not able to do the procedure which I am able to do this, because one can only hope that the surgeon of the 21st century will not judge us too harshly and will realize that we are captives of the time in which we practice. So technology is growing and we are captives of the nature in which we practice, and don't blame your few generation. Maybe that your next generation will blame you what these people are doing with all the gadgets of endoscopy and all that when the newer technology will come. Albert Einstein has told, as regards to technological development in surgery, I fear the day that technology will surpass our human interaction, the world will have a generation of idiots. And that is true, particularly for that. And therefore, the future of surgery in 22nd century, what will be there? Enchant a mantra, surgery is over. And surgeons are also over. And this is a new era of surgery coming soon. And where no team is required, no tool is required for that also. And the surgery will be like this, with the blessings, with enchanting and the mantra, all surgery will be done. No requirement of a team, no requirement of a tool and all that. And at that time, I will not be alive, but maybe that some of my next generation will speak of surgery. Today I have spoken team and tool. Now there will be no requirement of team, no requirement of tool. Thank you very much, ladies and gentlemen, for giving me this opportunity. And I am great for the break. And I apologize for being detained you for a few minutes for that. Thank you very much.
Thank you very much, sir. Thank you for very knowledgeable and informative lecture. And with your permission, we can take the questions.
Yeah.
Sir, there is a question from Latika Shukla. She is from Allahabad.
Yeah.
She's asking, sir, during cesarean, are you using ordinary suction apparatus fitted to silastic cuff?
Yes. Ordinary suction. Don't use the marketed specified suction for that. You ordinary suction. The Chignon is not required as used in the Maelstrom variety for that, and ordinary suction you use it for that.
Yes, sir. In continuation with the same question, she is asking whether silastic vacuum cup sterilized by autoclaving.
Autoclaving you can sterilize, or we can use it with the Paracef. That is not a problem for that.
Yes, sir. Next question is, what is the pressure used for diagnostic hysteroscopy with 2.9 millimeter hysteroscope?
Pressure. See, intrauterine pressure is a thing which normally with 80 millimeter, minimum 80 millimeter mercury, the uterine cavity can be visualized. That is accepted for that. Below that, it cannot be visualized. But if we adjust with the 80 millimeter, we are using a medium and there are some leakage through the cervix also. So we are not able to know what is the intrauterine pressure there. In the monitor, in the endomet, you can see 80 millimeter, but in the real sense, the intrauterine pressure will be less. So therefore, I told that you normally the complete visualization is achieved and well visualized, particularly for surgery, is achieved In my experience, it's up to about more than 100 to 150 millimeter. But I don't cross 150 millimeter. For that, I am not in favor of very high power or high pressure or low pressure. I think that's it. There are many people, there are two groups. There are some people who are very low pressure, and there are some people who favor high pressure. So high pressure is not, I want optimum pressure. At whatever pressure is visible, that is important for that. And that visibility will be minimum 80 millimeter mercury. And if depending on the leakage of the fluid, again, it will vary. It can go up to 200 millimeter also.
Yes, sir. Yes. As usual, there are many admiring messages there. I will just name few, sir, with your permission. Arun Kumar from Firozpur, Dr. Asha from Chennai, Tushar Dixit from Lucknow, Anshu Agrawal from Korba, Priti from Vadodara, and Sanjita from Raipur. So, and Bhishma Dev Kshatriya from Bhubaneswar. So all they are admiring your work, teaching passion and all. Yes,
Thank
sir.
you. Thank you. Very small topic, and I've selected this purposefully, that I don't think there is a tutorial class, but at least it will benefit all of you for the sake of surgery and as for sake of the knowledge.
Yes, sir. That's all, sir. Thank you.
Thank you.
very much.
Thank you. Thank you. And beg apology for the break.
Yes, sir. Yes. Recording stop karo. Admin.
Admin, please stop recording. Navala sir, thank you very much.
Thank you, Aditya.
Thank you, Sanjay.
Thank you, sir. Thank you.
Thank you,
To all
sir.
the team.
Thank you very much, sir.
Thanks to Bubu and Dev
Aditya,
for
last time,
immediate relieving my tension. Otherwise, thank you. It is closed, no? No recording?
Yes, sir. Yes, sir. It is closed now, sir. It's closed. We have closed the
Thank
link.
you.
recording
very
is not